Welcome to AETCM, the Emergency Medicine channel. Today, let us discuss and learn about normal chest X-rays and some of the abnormal X-rays also we'll discuss. So normally when we take an X-ray, we take chest X-ray PA view. We always write chest X-ray PA view, but in the ICU, emergency room and all, we write chest X-ray AP view. That is because patient is unable to stand. To take PA view, patient has to stand like this. That is very important. Patient has to stand like this. But when you want to take a chest X-ray in ICU, patient will be lying down like this. So that is a major difference. So here we keep the X-ray plate and X-ray machine will be taking like this. Here chest X-ray is taken. The plate is here. X-ray beam is coming from this area. So that is a major difference between X-ray AP and PA view. So PA view normally we take in routine practice, AP view we take in ICUs. So you can see here whenever we take an X-ray, whether it is AP view or PA view, so there are some differences that I will explain afterwards. Always try to see the lung fields. That is very important. We all know that lung contains air. Here you can see the air and here also air. So the air is very dark here. Air is black in color. So that is very dark in color. Here you can see it is not that much dark. It is slightly whitish. But this part you can see it is little bit darker than this part. So it is like this. So what you are seeing is lot of blood vessels are coming here. That blood is always white in color. You can see the heart that is white in color. So blood is always white in color. The mix of black and white here produces little less darker comparing with the other side. And then you see the exposure. Sometimes what happens is overexposed chest X-rays, like X-rays are overexposed means it will be darker in color. Underexposed means it will be white in color. And then try to count the ribs. The rib numbers I have given here. Count the number of ribs. Normally the 11th of 12th ribs, 11 or 12 rib cross the diaphragm at the midpoint normally. So when you ask the patient to take a deep breath and take the X-ray, 11th or 12th rib crosses the diaphragm. That is a normal X-ray. Sometimes what happens is patient may not take a deep breath. We take an X-ray, the diaphragm may be here. Okay, so that also can occur. So always try to count the ribs. Always try to see the lung fields, whether it is black or slightly lesser black, whatever it is. Then you can see here, this is heart. This is a heart. And next is clavicle. Always see the clavicle. Both clavicle should be equidistant from the midpoint. So that is very important. Equidistance has to be there. Sometimes what happens is patient is slightly tilted. Then the whole chest X-ray field may change. One side will come front, one side may go back. So that exposure also will be different. Now other things, aortic arch is there. You can see the aortic arch here, left lung fields, vessels. So this is the vessels, blood vessels, whitish color, and apex of the heart you can see, and diaphragm also you can see. So both diaphragm should have acute angles. That means this is an acute angle, this is an acute angle, this is an acute angle, this is an acute angle. If the angles are blunt like this, then there is some problem there. That we will discuss afterwards. So that is a basic of a chest X-ray what we are seeing here. Now chest X-ray PAV always we already discussed that see the color, outside color and inside color. This is more black in color. That means this patient can have even emphysema. We don't know what is a clinical picture, so we cannot comment. See the clavicle equidistance. Then try to count the numbers of the ribs. And during counting the ribs, you can also see any fractures or any swelling in the ribs. That also can be counted. Then see the aortic knuckle, pulmonary bed, left ventricle area, right heart area. Then see the pulmonary blood vessels, lot of blood vessels, white color you can see. When you are tracing the blood vessels, there are two views are very important. Normally when we are taking X-ray, you can see blood vessels will be like this. From the mediastinum, blood vessels will be going like this. But sometimes you can see this is a blood vessel actually. Black color thing or white color thing. One is inside, this will be black, this will be white. White is always a end-on view of an artery. So when the artery turns like this, when you're taking an X-ray, you can see white color. But end-on view of a bronchus that contains air, that's why it will be black. So that difference also you should know. But repeated X-ray reading only, you can see all these things. So these are the main things, and whatever you have to read, I have written here. We will not go to the details of that because these are the basics everyone should know. Then look at the cardiac costophrenic and cardiophrenic angle. That are two angles. Both angles we have already discussed. There should be acute angles. Then sometimes what happens is the angle will be blended. That means some fluid or something may be there. And right diaphragm is always little higher than the left diaphragm. That is because the heart is sitting on the left diaphragm. That's why the left diaphragm is slightly lower. That is very important. Now you can see even the trachea. In patients like this, trachea has to be middle. If it going to one side, that means something is dragging that to this side or something is pushing that to opposite side. Then see the lower mediastinum, here it is central. Sometimes it may go to either side. So it can be due to drag of mediastinum towards one side because of collapse or fibrosis, or push from other side, that is pleural effusion may push to opposite side. Then these are the main things you see. And heart also you can see is a heart. Normally the heart has to be the less than 50% of the total transthoracic diameter. So suppose this is transthoracic diameter is 10 centimeters. The heart should be only 5 centimeter, less than 5 centimeters. If it is more than 5 centimeter, here means if more than 50% of the transthoracic diameter, then there is a problem that heart is enlarged. But that should be commended only in a chest X-ray PA view. Now when we are reading an X-ray, we should remember that X-ray are read in this type: upper zone, right upper zone, right left upper zone, right mid zone, left mid zone, right lower zone, left lower zone. First two to three ribs will be upper zone. Then another 2 to 3 ribs will be the middle zone. Last zone will be lower zone. Don't comment upper lobe, middle lobe, lower lobe in an X-ray because the X-ray reading is only 2D. When we get a 3D image only, we can tell whether it is upper lobe, middle lobe or lower lobe. So that we should remember. Just comment about upper zone, mid zone, lower zone. Now there are a lot of structures here, you can see here, but I am not going to comment all the structures. But basically you should know that upper zone is upper part of the lung, mid zone you have heart and the mediastinum, lower zone is the lower part of the lung, diaphragm, cardiophrenic angle, costophrenic angle, all these things. Now when you have a lesion like this, so what you are seeing here is a lesion. You can see the white patch in the right upper zone. So when you have a right upper zone, always you want to know whether it is in the upper lobe or middle lobe. You can take a lateral view of X-ray. But nowadays we don't prefer to do all these things because one X-ray itself you can see there is a right upper lobe white shadow. A white shadow has got a lot of differential diagnosis. White shadow can be consolidation, that is pneumonia. Consolidation, collapse. Collapse also will be white color, mass. These are the major differential diagnosis for a white homogeneous opacity. But this you can see there is a round opacity in the right midzone, mostly a malignancy. Suppose this is collapse. If it is collapse, then you can see the trachea may be deviated slightly towards this side. This rib spaces, you can see the rib spaces that may be narrowed. The rib spaces can be narrowed when we compare with the opposite side. So here the PA film shows it's above horizontal fissure. The horizontal fissure is here. You can see the horizontal fissure. You can see the horizontal fissure here. Horizontal fissure here. Now, right upper lobe lesion can be due to pneumonia or tuberculosis. We have seen that previously. A mass or collapse also can produce same thing. mass, we have to see the history. Suppose the patient is having weight loss, hemoptysis, chronic smoker, then you have to suspect a mass. Suppose this patient is having last 3-4 days severe cough, breathlessness, hemoptysis, then it can be pneumonia. If the patient is having last 2-3 weeks fever, anorexia, mild weight loss, evening rise of temperature, then you have to suspect TB. But suppose this patient come with severe cough and hemoptysis last 3 days. What you are seeing is a right upper zone and mid zone homogeneous opacity. Homogeneous means throughout the length field same type of pattern. Homogeneous opacity, white in color. You can see the trachea that is not deviated to this side. You can see the interlobar fissure that is sagging down. That means there is consolidation here, and because of edema this interlobar fissure is sagged down. So that means pneumonia. Pneumonia, especially Klebsiella pneumonia, affects the upper lobe. But if it is in tuberculosis, what happens is this, there will be collapse of the lung field, so these rib spaces may become narrow and this interlobar fissure may become dragged upwards, and if even the mediastinum may drag towards that side. So mostly this is upper lobe consolidation due to Klebsiella pneumonia. Now what you are seeing here is there is a lesion here. You can see here there is a lesion. Trachea is slightly deviated to this side and interlobar fissure is dragged upwards. That means there is a loss of lung volume there. It can be collapse, it can be consolidation by TB. Okay, TB is a consolidatory lesion, but it can produce loss of lung volume. Even a post pneumonia consolidation also can present like this. That all depends on the clinical history. Suppose this patient is having 1 month history of fever, evening rise of temperature, then this has to be TB. Suppose this patient is having only 4-5 days history of fever and suddenly patient become more breathless, means it can be even upper lobe collapse. Now what you are seeing is a right mid or lower zone consolidation. What you are seeing is a consolidation. What you are seeing is here a consolidation, and what you are seeing here, this is a air bronchogram. Air bronchogram means inside the pneumonic consolidation, the bronchogram you can see in black color. Okay, that is a airways that is not collapsed. So that is called as air bronchogram. You can see the air bronchogram and this consolidation on the paracardiac area, and you are not able to see the cardiac shadow properly. This is called as silhouette sign. Silhouette sign is a very important sign. You can pick up the middle lobe pneumonia here. So normally when you are commenting about pneumonia, you are telling right mid and lower zone consolidation. But if you are seeing the consolidation on the right paracardiac area, and if you are not able to trace the cardiac shadow properly, then it has to be in the middle lobe. Okay, whatever it is, that is a pneumonia because of the air bronchogram. Now, right lower lobe pneumonia is very important. You can see here the consolidation here, white homogeneous opacity on this side. You can even see the cardiac border properly, so it is not in the middle lobe. And on the lateral X-ray also you are seeing the same thing. And you can see the air bronchogram here very clearly. So here also you can see. So air bronchogram is there. So it has to be right lower lobe pneumonia. But we should remember, we always should tell it as right lower zone. And if you are confident only, then you can tell right lower lobe pneumonia. But when you are commenting, normally comment that right lower zone pneumonia. Now another X-ray, what you are seeing is a right lower zone. There is a white homogeneous patch. You can see here a white homogeneous patch. But what happens is the cardiac shadow is grossly shifted to this side and diaphragm is gone very high. That means this part is collapsed. That may be due to a lymphadenopathy or any pneumonia. That part can be collapsed. So pneumonia will produce collapse because of the bronchus, and mucus plug will obstruct and remaining part of the lung will collapse. Okay. Even a lymph node in the mediastinum can also produce same effect. This part is blocked, so the lung will be collapsed. Okay. So collapse can be there. That is indicated by mediastinal shift towards this side. Now, mediastinal widening is another problem. So you can see here this X-ray. What you are seeing is the white, yellow arrows. You can see mediastinum is widened. Okay, this can be due to mostly lymph nodes, tumor, whatever it is. Okay, but mediastinum is widened. This patient require a CT scan. This is not pneumonia. This is a wide mediastinum, mostly due to lymphadenopathy like tuberculosis, sarcoidosis, or malignancy, or any other metastatic lesion. All these things can produce mediastinal widening. Even aortic aneurysm also sometimes can produce mediastinal widening. Now, this is a chest X-ray AP view. That means this X-ray is taken in ICU. Patient is lying down. You can see a lot of wires are here that is connected to monitor. What you are seeing here is mediastinum is widened. That is because when you are lying down, the diaphragm has gone up. That means the heart is compressed from the back, from the lower aspect. So the mediastinum is automatically widened. Okay, that pressure will widen the mediastinum. That's all. It is not actual mediastinal widening. That's only because of the lying. This one patient's mediastinum is widening. Now always look at the diaphragm here. You can see the diaphragm is in the middle. Clavicles, everything is normal. This is a good X-ray. Now pleural effusion is another X-ray. You can see here. So normally when you see the angles of the lungs, the angles are always acute. But here you can see the blending of the angle. Both sides it is blended. So that is because of the effusion. So fluid is there. That fluid will push the liver to this side and it will produce a blended angle in X-rays. So that is pleural effusion. Here little more effusion. You can see it is going like this. This is an encysted effusion, mostly seen in tuberculosis. Here also it is like this. So this is also encysted effusion. Okay, encystment is classical finding in tuberculosis. Encysted means there will be fluid surrounding that. There will be a layer will be formed. That layer will be always. It will, most of the time, X-ray it will be seen as like this. Now, when we have a pleural effusion in lying down posture, always remember when you are lying down, the fluid will accumulate in the lower part of the chest. That is very important. When you are lying down, pleural fluid will accumulate in the lower part of the chest. So when you are taking an X-ray in lying down, throughout the lung field it will be white in color. Okay. So that we have seen that when you are lying down, fluid is accumulated on the lower part. When you are taking an X-ray, it will be spreading throughout the field. So you get a uniform white color. This is called as ground glass appearance. Ground glass appearance is classically seen in pleural effusion when the patient is lying down. Okay, but always we should remember one important thing, that when we are standing, fluid will be like this. When you are lying down, fluid will be like this. Throughout it will be spread. So now we see hydropneumothorax. That is the next thing. Hydropneumothorax means if the patient is having pneumothorax, here this much pneumothorax is there, that's why it is black in color. The outside color you can see, here also you can see it is more black, and there is a flat line. So remember, a flat line always indicates this part air is there. Air is compressing the water, that's why it is hydropneumothorax. So you can see here, this is pleural effusion. Pleural effusion will have that peculiar nature, and this is pneumothorax. When pneumothorax pressing the fluid like this, you get hydropneumothorax. Hydropneumothorax can be seen in patients who is having previous emphysema after tapping of pleural fluid, or in trauma, chest trauma, all these things you can get like this. Now, bronchiectasis is another problem where there is dilatation and destruction of terminal bronchiole. You can see here, terminal bronchiole is destructed. You can see it is like small holes in the lung fields, black color holes. Throughout the lung fields, you can see black honeycombing appearance. That is seen in the CT also. So, always take CT to confirm it, but X-ray itself you can make out. Here also you can see lot of black color holes that is in the lungs. So that is due to bronchiectasis. The problem with bronchiectasis, this patient can bleed, this patient can get infection. So this patient can
can be admitted with repeated infection, patient can be admitted with repeated bleeding or hemoptysis. So the treatment will be mostly removal of this lobe, lobectomy. So next is pneumothorax. What you are seeing here, you can see this part is black in color, this part is white in color. This is lung field, more whitish here, and the air which is trapped here, this is pushing the lung towards this side, and you can see here clearly there is a clear-cut lung margin. Okay, so that is pneumothorax. Here also you can see here there is a clear-cut lung margin. Follow this. There is a clear-cut lung margin. So that is due to pneumothorax. Air inside the lungs that is pushing the lung field towards the mediastinum. Okay. Sometimes it can be tension pneumothorax. Tension pneumothorax means air may come from outside. Every breath, air may come from outside. Slowly, this will be compressed. Now, emphysema is another important condition in smokers, especially chronic smokers. You can see here the dilatation of lung fields. There are some peculiar features. You can see here heart is tubular. That is very, very important. Tubular heart. That is most important because lungs are pushing the heart like this. Diaphragm is low and sometimes it will be flat. So flat and press down lung fields, diaphragm. That is because, again, it is because of air, and a lot of blood vessels in the lung fields. Something like dirty lung fields. That is because of the increased inflammation in the parenchyma. Okay, that is emphysema. Now, when we discuss emphysema, we should remember about barrel chest. Barrel chest means both anterior posterior and transverse diameter will be equal. Okay. So there is a difference in emphysema. The lateral chest X-ray is taken more black in color. This diameter is small. More black in color means more air is trapped inside the lungs. Now pneumonia, again when we are discussing about pneumonia, you can even tell it is lobar pneumonia or other pneumonias or not. These are homogeneous opacity seen in the right lower zone. There is an homogeneous or non-homogeneous opacity seen in the left upper zone. You can see lot of blood vessels here. This is air bronchogram, classical finding in pneumonia. So that is consolidation. Now bronchopneumonia means even in the small air spaces also pneumonic infiltrations are there. So multiple areas it is infiltrated, mostly seen in viral pneumonia, ARDS, rarely TB also, that is miliary mottling also can be there. But most of the time bilateral extensive pneumonia like this is seen in viral pneumonia. It is bronchopneumonia, mostly H1N1 or COVID, whatever it is. Staphylococcus also can present like this, bacteria, among bacteria. Now, cardiogenic pulmonary edema, what we have seen in the previous slide, normal heart, that means heart is not dilated, bilateral extensive areas. But here what you are seeing a very large ventricle, a lot of blood vessels here, bilateral multiple infiltrates. Here also heart is very big. That means this patient has developed cardiomegaly with cardiac failure that has produced pulmonary edema. So this patient may have acute breathlessness, sudden onset of breathlessness. Patient may require BiPAP or NIV ventilation, all these things. Now, phantom tumor is a tumor which can disappear. This is due to the fluid accumulating in the interlobar space. This can disappear after giving gases. So that is mostly seen in cardiac failure. You can see that it looks like a tumor, but once you give Lasix and initiation of NIV, this will disappear. Okay, this is the interlobar fissure. You can see here interlobar fissure is full of water, so white in color. So that is due to cardiac failure. So now any patient admitted in ICU who is having a few days breathlessness and all, you have to see that bilateral extensive shadows, that is due to ARDS, acute respiratory distress syndrome. Now, tuberculosis mostly occurring in the upper lobe of the lung fields. You can see the cavitated lesion here. So, cavity is there, upper part is air, lower part is liquid, and this inner lobar fissure is drawn upwards, that is due to loss of lung volume, and there is a slight deviation of the trachea towards this side. So, we have discussed some of the common chest X-rays which come across our clinical practice. I didn't discuss the complete X-ray, that takes longer time. So, we have only discussed that some of the important features in chest X-ray. Thank you.